Hello, and welcome to the Innovation Institute of Online Education and Training. This training comes to you as part of our wellness series led by the internationally renowned nutritionist, best-selling author, and founder of the Fellowship in Anti-Aging, Regenerative, and Functional Medicine, Dr. Pamela Warshon-Smith. Dr. Smith spent her first 20 years of practice as an emergency room physician before gaining her 25 years of experience as an anti-aging functional medicine specialist. Whether you are new to the topics that we'll explore in this presentation or hoping to learn new ways to expand upon your current standards of practice, we believe that Dr. Smith will far exceed your expectations. At the close of this webinar, I'll come back to tell you how you can receive answers to any questions you may have and provide information for how to get in touch with our pharmacy. We appreciate you taking the time to join us today, and now let's hear from Dr. Smith.
Hi, this is Dr. Pamela Smith. We're now going to spend a little while looking at why your patient can't lose weight. Obesity is one of the great medical challenges of our lifetime. There's 1.6 billion adults currently classified as being overweight and 400 million as obese. According to the National Health and Nutrition Examination Survey, 35% of men and 40.5% of women in the US are literally obese, meaning a BMI is greater than or equal to 30. Being overweight or obese increases the patient's risk of 35 major diseases. Even a 3 to 10% reduction of total body weight is enough to have a clinically significant benefit for diabetes prevention and symptoms of osteoarthritis, hyperglycemia, hypertension, and dyslipidemias. Some of the references today will be on the slides, and some will be in my book, Why You Can't Lose Weight. Anyone who would like a copy, we are happy to get you one wholesale. Being overweight or obese does increase the patient's risk of developing the following cancers: postmenopausal breast cancer, endometrial, esophageal, gallbladder, kidney, pancreatic, and thyroid cancer. Being overweight or obese also increases the risk of dying of cancer if they get a cancer. Increased body fat elevates the levels of estrogen, blood sugar, and insulin, and inflammation. All of these are risk factors for the patient developing cancer. And I'll never forget the first time I gave a seminar to patients inside the hospital on a cancer ward. They wanted me to come in and talk about cancer and quote unquote alternative therapies. And as I spoke, the patients started dropping their food because, as you're about to see, it does matter how people eat and what their blood sugar is and whether they develop cancer or they beat their cancer. The hospital was literally feeding the patients donuts. The direct and indirect cost of obesity, including medical services and lowest productivity, amounts to more than 117 billion with a B dollars a year. It's not only important to help your patients lose weight, but just as important to help your patients keep it off. One study revealed that only 1 in 6 overweight and obese adults reported having maintained weight loss of at least 10% for over 1 year. Why is this? Weight loss, honestly, it's a multifactorial problem because weight gain is a multifactorial problem. Patients intake more calories than they burn in a day. This is huge. I just dined with someone in the last week that said that they wanted to lose weight. They wanted to lose 100 pounds. And the food that she ate that was served, literally the chips, salsa, etc., before we had the meal was already 1,000 calories that she ate. And she couldn't understand how she couldn't lose weight. Allergies is a big problem. Hormones, if they're not balanced, neurotransmitter dysfunction, whether the patient can detoxify well, whether they're inflamed or not. Honestly, if they're overweight, or obese, they are inflamed by definition. Sleep deprivation, yeast, fiber, water, exercise, artificial sweeteners, food additives, high fructose corn syrup. There's a lot of things to talk about. A healthy eating program is key. In my personal practice, we honestly don't use the words diet because people then think that's deprivation. And if I say, oh, this is Friday, I'm actually going to go on a diet on Monday, they will feel like they're going to be deprived. They're not thinking of it as a lifestyle change, and they will actually gain 5 pounds between Friday and Monday because they think they're going to be deprived. So, healthy eating program. Honestly, we really don't use the words diet. And patients don't understand that if they eat perfectly and then they eat badly, they set themselves back 3 days. So if they ate perfectly all week, except for Monday and Thursday, they ate poorly, they would never lose weight because every time they eat something bad, it literally sets themselves back 3 days. So most patients, it needs to be literally a lifestyle change. Healthy eating really should be a permanent thing if they want to lose weight and just as importantly, keep it off. Decreasing caloric intake if the patient is eating too much food does help. So, what are some of the primary factors that affect metabolic rate? Because how fast they burn calories does matter. Age is one of those. Metabolism peaks during late adolescence between the ages of 15 to 18 for women and 18 to 21 for men. Certainly over the age of 25, it becomes harder to lose weight. And as one ages, it slows by about 3 to 5% a year their metabolic rate. Gender does matter. It's really hard with patients that are female. Men burn calories faster at any weight than women do and at any age. Climate, warmer weather lowers the metabolic rate because the individual spends less energy keeping themselves warm. State of consciousness. For most of the time, one is asleep. The brain slows body functions. The heart rate, breathing, digestion go down, so the metabolic rate goes down. How about thermogenesis? The higher the amount of protein in the diet, the more thermogenesis is increased. So instruct the patient to increase protein in their diet. And then, of course, caloric restriction. A high calorie content in a meal can raise insulin levels and increase inflammation. Caloric restriction promotes weight loss in a bunch of ways. First of all, high calorie meal can raise insulin. High calorie meal drives up inflammation, and a high calorie meal disrupts the signaling balance in the hypothalamus of the patient feeling satiated and the hunger hormones, and it increases the patient's appetite. So the hypothalamic hormonal function changes. Exercise. Increasing exercise if the patient's not exercising is important, or exercising the right amount is just as important. Exercise does promote weight loss. It aids in increasing metabolic rate. It increases the activation of brown fat, which burns fat. It elevates the activation of the SNS, which aids in burning fat. It increases growth hormone, which helps with weight loss. It improves insulin sensitivity, and it helps fat loss while maintaining lean muscle. But if the patient aggressively exercises, they're exercising 7 days a week and pumping iron, and they're not losing weight, one of those reasons can be they don't have enough nutrients. If the patient exercises 7 days a week, that's aggressive exercising. Then they get literal nutritional depletions, so then they don't burn fat. So they do get depleted in Q10. They get deplete in alpha lipoic acid. They get deplete in D-ribose, magnesium, NADH, and other nutrients. So you may need to literally go back and refuel the mitochondria. How much Q10 does that take? 3 to 400 milligrams a day. How much alpha lipoic acid? The same amount. D-ribose, about 15 grams. NADH, 10 milligrams twice a day. And magnesium, I usually use magnesium glycinate for this purpose, at least 400 milligrams a day to bowel tolerance. Allergies are a major reason why people can't lose weight. Weight gain may be due to allergies to food or food intolerances. When the immune complexes form, the bodies retain fluid to try and dilate or dilute the complexes and make them less concentrated. This excess fluid causes weight gain. 60% of the US suffers from undetected food allergies. People commonly crave food they're allergic to. And if they go to their allergist, they just get IgE allergies measured, not IgG. It's important to measure both. A lot of people have IgG allergies. This is a humoral response, and the patients don't experience the symptoms, whether it's weight gain, whether it's flushing, or even epinephrine and norepinephrine going up for a couple of days. And people tend to eat foods they have intolerances to because they crave them. Literally, epinephrine and norepinephrine do go up. They literally get a high from these foods. The top 4 foods that cause allergies are wheat, dairy products, soy, and eggs. Other common foods that are frequently a problem: barley, beef, chocolate, citrus, coffee, nuts, rye, seafood, sugar, tea, and tomatoes. Food allergies also influence the limbic region of the brain. This is associated with the hunger response. And food allergies are false kinins that can cause inflammation and interfere with neurotransmitter function. This can also cause weight gain. So allergic reactions also directly affect the central nervous system and mood. There's also a psychological component to weight gain. Some people use it as a reward. Some people use it for anxiety and depression. Sometimes people have a cue. One of the physicians in my own personal practice, when she gets done seeing patients, rewards herself by eating a chocolate bar. So if she sees patients 5 days that week, she ate 5 chocolate bars. And she was wondering why she wasn't losing weight. It was actually kind of subconscious to her. Hormones. Of course, adrenals. Who isn't stressed in today's world? Stress is a major factor that can lead to weight gain. The most stressful jobs are listed here on the slide. If the patient stays stressed, it's hard to lose weight and keep it off. The things that they have in common here with the most stressful job is lack of control. People don't have any control over their lives. It commonly causes stress. So the patient cannot control the factors that cause stress, but they can control their response to them. There is a strong interrelationship between the activation of the hypothalamic pituitary adrenal axis and energy homeostasis. Patients with abdominal obesity have elevated cortisol levels. Stress and glucocorticoids also act to control both food intake and the expenditure of energy. In addition, glycocorticoids are known to increase the consumption of foods enriched in fat and sugar. It's well known that in all species, the cortisol response to stress or the adrenocorticotropin is highly variable. It's now really emerging that cortisol responses, very important determinant to metabolic sequelae to stress. And this complex set of traits leads to increased food intake, reduced energy expenditure, and high cortisol responders. And this literally predisposes this patient to obesity. So I do salivary testing on these patients. Medical studies have shown that salivary testing is the gold standard to look at DHEA and cortisol. I'm not talking about Addison's or Cushing's, but looking at hormonal balance and the HPA axis. It's all about looking at salivary testing. Cortisol responsiveness may be used as a marker to identify individuals who are at risk for weight gain and subsequent obesity. In this study dating back to 1994, the authors predicted that cortisol responsiveness may be used as a marker to identify individuals who are at risk for weight gain and subsequent obesity. So it did matter the abdominal fat distribution. When somebody is stressed, their adrenal glands literally go into a state of emergency if they stay stressed. The body thinks they're not going to be able to find food for a week. So it goes into a state of emergency, meaning that it stores everything that goes into the body. Even if they're eating peaches, plums, nectarines, and pecans, it stores things long term. And there's only one way the body stores things long term. It is stored as fat. People can get addicted to this high feeling when they stay in a state of emergency. When the adrenal glands have been stressed for a long time, they do become fatigued. Then people do what? They feel like they're going to crash, so they go eat more sugar. They have more caffeine. It boosts their energy, but only for about 2 hours. It literally makes the situation worse. Most physicians and other healthcare practitioners have adrenal dysfunction. In fact, honestly, since COVID, I haven't seen a normal cortisol test, well, probably for a year and a half now. So when it comes to female hormones, it's a little bit different. Men, their testosterone levels change 4 to 6 times a day. For women, before menopause, they have 28-day hormonal fluxes. So it depends. PMS, PCOS. Many patients with PCOS have insulin resistance. Perimenopausally, if women are estrogen dominant, they tend to gain weight. And as women go through menopause, as estrogen declines, insulin sensitivity becomes dysfunctional. Testosterone also affects insulin function. As women go through menopause, one half maintain their normal testosterone. Of that remaining one half of those testosterone goes up, which causes insulin resistance. The other half, testosterone becomes too low, and then the patient does not burn fat. But this is also true of men. Testosterone does go down with andropause. Testosterone increases muscle mass, it lowers cholesterol, blood sugar, blood pressure, and it really does help with weight gain. How about pregnenolone? The hormone that is the hormone of memory, but it's also the one at the beginning of the steroidogenic pathway. Pregnenolone levels do decline with age. It is a precursor to estrogen, progesterone, testosterone, DHEA, and cortisol. If the patient is eating the wrong foods, then the body's pregnenolone is blocked. If they have too many saturated fats and trans fats, then the rest of their steroidogenic pathway does not work very well. And of course, the hormone insulin. Insulin resistance is a common cause of weight gain since the body is not effectively processing glucose. Elevated insulin increases the ratio of fat to muscle. An increase in insulin decreases fat burning. But most doctors never measure the hormone insulin itself. The hormone insulin perfect is 6. Too low of insulin or too high is insulin resistance and a pre-diabetic state. If insulin levels stay elevated, the stored fat and adipose tissue will remain sequestered, due to its inhibition of the hormone-sensitive lipase in healthy fat cells. Insulin in the blood increases hunger. So if insulin levels go up, then the patient gets hungry. It helps lower blood glucose levels, and elevated insulin levels caused by inflammation in the muscle cells will keep insulin levels persistently high. Insulin resistance also impairs the body's ability to produce serotonin from tryptophan. So the happy neurotransmitter doesn't get produced as well either. And of course, thyroid. We've probably known this for over 60 years. Thyroid is the conductor of the hormonal symphony, and thyroid hormones modulate carbs, proteins, and fat metabolism. Hypothyroidism can commonly lead to weight gain. A study found that a euthyroid patient's plasma leptin and TSH levels correlate, and both are positively correlated with adiposity. Plasma leptin was significantly elevated in hypothyroid patients to levels similar to those seen in obese euthyroid subjects. So treating hypothyroidism resulted in the clinical trial in a reduction in the raised plasma leptin levels. And there's your trial. More recent data disclosed a relationship between obesity and thyroid autoimmunity. Remember, patients that are hypothyroid, 70% of them, 70% of them do have Hashimoto's thyroiditis. So you end up commonly with an autoimmune response. Also, the adipocyte hormone leptin appears to be the main factor linking the Hashimoto's and the weight gain. This study from 2017 revealed that higher baseline free T3 and free T4 predicted more weight loss, but not weight regain among overweight and obese patients with normal thyroid function. So it is important to get all the thyroid panel: TSH, free T3, free T4, reverse T3, and thyroid antibodies. Just to get a TSH or TSH and free T4 is not enough. Melatonin. It's made from serotonin under the regulation of norepinephrine. Low levels are associated with insomnia and a major decline in the immune system. The patient does not have a good sleep hygiene. Their insulin levels rise and they tend to gain weight. So hormones are huge when it comes to whether the patient loses weight and keeps it off. But it's not just about thyroid hormone. It's also not just about hormones. Neurotransmitters. Neurotransmitters are chemical messengers that relay signals between nerve cells, inhibitory and excitatory neurotransmitters, and they need to balance. The inhibitory decrease the ability to send signals. They do have a calming effect. GABA, serotonin, glycine, taurine, agamatine. GABA does occur in 30 to 40% of all nerve endings. It does require pyridoxal 5-phosphate as a cofactor and B6. It has a lot of functions in the body. It does calm and it aids in secreting growth hormone. Serotonin. It's made from tryptophan and 5-HTP. It's made in the brain, platelets, retina, and GI tract. In fact, most of serotonin, 90%, is made in the GI tract. So if the gut's not healthy, the patient's not healthy. If the gut's not healthy, the patient will have a hard time losing weight and keeping weight off. Tryptophan. It works best if it's taken with B6 and carbs. Tryptophan makes serotonin. It acts as a mood stabilizer. It helps with insomnia, increases the release of growth hormone, suppresses appetite, and needed for the production of vitamin B6. And 5-HTP does decrease carb cravings. It aids with stress reduction. It helps with sleep, decreases depression and anxiety, and makes serotonin. Glycine. Function of glycine, many, they're listed here on the slide, but when we're talking about weight, glycine decreases sugar cravings. Taurine, when people are stressed, B vitamins become deplete, and so does the amino acid taurine. It does require zinc to function properly. Taurine is made from methionine and cysteine, and it aids in glucose metabolism by increasing the activity of insulin receptors. It improves insulin sensitivity. It detoxifies substance. It's a natural diuretic. It boosts antioxidant defense. It's needed for all these other functions as well, including immune function. Agometine modulates the action of glutamate. It is a metabolite of arginine. It's needed for the secretion of glucagon and insulin. It increases the production of growth hormone, enhances fat metabolization, improves GI health, and builds muscle. The excitatory neurotransmitters, and you can do a neurotransmitter test. It is a urine test. We don't have to guess on neurotransmitter function. So the excitatory, you can measure epinephrine, norepinephrine, PEA, histamine, etc. When we look at epinephrine and norepinephrine, epinephrine is made in the adrenal glands from norepinephrine. Norepinephrine is synthesized from dopamine. Contributes to anxiety. The levels are abnormal. The body does need copper and vitamin C as cofactors. PEA is made from phenylalanine and promotes energy and improves mood, and histamine has a pacemaker function in the brain. Aspartic acid and glutamate. Aspartic acid is made from glutamate. Glutamate is the main excitatory neurotransmitter in the brain. It's used by 70% of the excitatory synapses, and glutamine has numerous functions. It balances blood sugar, helps maintain a healthy gut, elevates growth hormone, decreases toxins, and it fuels the source for immune function. Dopamine is very unique. It's both inhibitory and excitatory. It's made from tyrosine. It makes epinephrine and norepinephrine. It also plays a role in hormonal, CNS, and cardiovascular and kidney functions. It aids in movement, helps with weight maintenance by increasing satiety. So the patient is not going to feel satiated without dopamine being normal. So neurotransmitters do affect weight. So you can look at it from the viewpoint of insomnia, depression, anxiety, stress levels. So this is a common pattern you would see in people with insomnia. This is a common neurotransmitter pattern for depression. Here's one for anxiety. And of course, looking at stress. We've talked about stress. Cortisol levels reduce anxiety and stress by decreasing the release of epinephrine and norepinephrine. It's all about balance. The body has many organs of detoxification. The largest organ of detoxification by the body is the skin. But how the skin looks is very much related to another organ of detoxification, the GI tract, the gut. Liver is an organ of detoxification. Obviously, the kidneys are as well, the lungs, and the lymphatic system. In order to lose weight and keep it off, the body does have to be able to detoxify. Exposure to toxins is increased by eating a diet high in processed foods and fats, drinking tap water, excessive consumption of caffeine containing beverages, alcohol consumption, tobacco use, recreational drugs. That's becoming a bigger issue in today's world. Chronic use of medications and exposure to toxic metals. Other toxins, the body does build up toxins if you don't exercise. Your patient needs to understand, even if they're like me, I hate exercising. I do not get the high that a lot of people get from exercising. I exercise to maintain memory. Get the patient's attention. Maybe it's not about weight for them. but they will have weight loss if you say, hey, your mom died of Alzheimer's. Let's get you out there exercising to maintain memory. Other exposure to toxins can be due to liver dysfunction, kidney problems, GI dysfunction, occupational exposure, using pesticides, paints, etc. Really, the great question is, how much load are you carrying? How much load is your patient carrying of toxins? So, phase one, phase two detoxification of the liver can be measured. So, phase one, certain enzymes change toxins into intermediate compounds. But a lot of people get stuck in that intermediate section and then they don't fully detoxify into phase two. They get stuck in between phase one and phase two. Commonly, people will have even more toxins than they started with. The GI tract, it's hugely important to look at GI function. You have a great compounding pharmacy that you're working with that specializes in GI detoxification and looking at GI function. It's something you can do in your practice. It's something the pharmacy can do with you, for you, to help the patient be healthy. The GI tract has major metabolic activity, even greater than the liver. If the microbiome is unhealthy, it does increase the risk of developing infections, obesity, insulin resistance and diabetes, dyslipidemia, hypertension, cardiovascular disease. I could have added cognitive decline there. The prevalence of which microbiome species is present in childhood may be linked to the patient being overweight or obese later. One study showed that normal weight infants had higher levels of bifidobacteria than children of the same age who developed obesity by the age of 7. Breastfeeding plays a major role in determining the microbiome composition. Study showed that high levels of some lactobacilli can actually cause weight gain and hyperglycemia. So we can measure the actual genome. We can look at the family and the phylum and determine, do we have the right mixture, the right diversity for the patient to lose weight and keep it off. The GI tract is also involved in neuroendocrine regulation. Again, 70% of the immune system is in the gut. Many other things besides serotonin are made in the gut: vitamins B12, biotin, vitamin K. If the patient has too much bad bacteria, then they develop dysbiosis, which can lead to leaky gut syndrome. Dysbiosis and leaky gut are associated with adverse health conditions, many of them including obesity. Lower microbial diversity is associated with obesity and fat mass variable, particularly the visceral fat mass. In this study, lower gene count is associated with more marked weight gain over time. Patients that are overweight do tend to have differences in the diversity of their microbiome. There's a lot of studies showing that now. And studies have shown that changes in the microbiome in grossly overweight patients after the metabolization of food alters energy harvest and fat storage. Metabolic changes due to altered microbiome and obesity also increase insulin resistance. So, in other words, the altered gut microbiome will change what short chain fatty acids are made. This affects gut peptide secretion. It affects whether achromasia is there. Achromasia is the bacteria, the keystone bacteria that helps burn and helps insulin work better in the body. So the standard American diet is indeed SAD. That acronym is true. Short chain fatty acids have a role in both glucose and lipid metabolization and the immune system. So a diet that's high in bad fats and low in fiber leads to dysbiosis and increased intestinal permeability, which means leaky gut, and that leads to inflammation. So when you have metabolic endotoxemia, this indicates an increased plasma concentration of lipopolysaccharide components that are found on the membrane of the gram-negative bacteria. So more LPS goes into circulation. This is due to increased intestinal permeability, and then you end up with mesenteric adipose tissue and blood accumulating and intestinal permeability. That is not perfect. Dietary manipulation of the microbiome to control obesity includes prebiotics, probiotics, symbiotics, and things to help with inflammation. So you can look at the 4R program, or what we lovingly now call the 5R program, where we added rebalancing. So remove the offending agents, replace digestive enzymes and other things that you find on the gut health test, repopulate with good bacteria, actually restore with glutamine, quercetin, butyrate, and fix literally the mucosal lining of the GI tract and rebalance the patient from a psychological viewpoint. Specific probiotics do promote weight loss. So Bifidobacterium animalis species lactis B420 has been shown to have the following beneficial effects. So you can see here a trend toward a decrease in zonulin levels and C-reactive proteins. You have inflammation going down, a decrease in TNF alpha, other inflammatory markers, increase in good short-chain fatty acids like butyrate. And of course, skin detoxification, great to looking at detox, infrared sauna, a beamer. There isn't any disease process after the age of 45 that a patient can get that is not related to inflammation. So inflammation and weight loss, when a patient's overweight, this sets up an inflammatory response in the body. Inflammation is used by the body to heal. A small amount of inflammation does heal. Too much causes disease. So adipose tissue produces several different adaptogens, including hormones and inflammatory mediators that produce chronic inflammation. One of these adaptogens is leptin. Leptin works on the brain to inhibit food intake and activates thermogenesis in conjunction with insulin. So how do you raise leptin if the levels are low? Because catecholamine levels lower it. To raise it, weight loss, improvement of insulin function, and lowering cholesterol and triglycerides. Obese patients do tend to be leptin resistant. Adiponectin, it's a protein hormone that modulates a number of metabolic processes, including glucose regulation and fatty acid oxidation, and synthesized in and secreted by adipose tissue. Adiponectin is a hormone that the body makes less of when the patient's overweight, and if there's insulin resistance or diabetes. So adiponectin regulates glucose, lipid catabolism, insulin sensitivity, protects the endothelial lining. So if it's not working correctly, you end up with endothelial dysfunction, promotes weight loss, upregulation of uncoupling proteins, controls energy metabolism, and reduces TNF alpha. Adiponectin production is decreased by catecholamine production, an increase in TNF alpha, and elevated interleukin 6. Both of those are inflammatory markers. ASP is a hormone produced by adipocytes. It's of importance for the storage of energy as fat. ASP is increased by insulin, and it augments glucose, stimulating insulin secretion. It has a direct action on the islet beta cells. It goes up after eating, and it's high in people that are overweight. And of course, C-reactive protein. Obesity is associated with an elevated CRP, so the patient literally is inflamed. Chronic psychological stress can set up an inflammatory response in the body as well. When the patient loses weight, CRP tends to go down. The body does require good fats to decrease inflammation, prevent disease, and promote weight loss. Fatty acids have a lot of different functions in the body. Weight gain is one of the symptoms of essential fatty acid deficiencies. Again, we can measure fatty acids. We don't have to guess whether we need more omega-6, 3, or 9. Other clinical manifestations of essential fatty acid deficiency beside weight gain: dry, scaly skin, dermatitis, dry hair, dandruff, excessive thirst, brittle nails, decreased memory and mental abilities, psychological disturbances, compromised immune system, fatty infiltration of the liver, numbness and tingling of the arms and legs, reduced vision, increased cholesterol, mood swings, depression, arthritis, and all of these things as well. So if you look at this, think of your patients. Cracking skin at the fingertips and nails. Think essential fatty acid deficiencies. So how does a patient get deficient in fatty acids? Of course, a decreased intake of the right kind of fats, stress, inability to absorb fats, alcoholism, type 1 diabetes, and a decrease in nutrient cofactors: zinc, magnesium, niacin, vitamin C and B, biotin, B vitamins, and carnitine, an increase in trans fatty acids, and increase in sugar intake. Now remember, when it comes to carnitine, you just can't give carnitine to everybody. If the patient has a high TMAO level, which is 1% of the population, you can measure that by doing a blood study at any major lab. They have a high TMAO, then you cannot give choline, you cannot give carnitine as a supplement. Those patients should not eat red meat, and those patients should not eat egg yolks. The body does need more omega-3s than the standard American diet usually offers. In fact, fatty acid supplementation can change the amount of medication people need. A study showed some people needed less Prozac. Omega-3s and polyphenols have been shown to decrease inflammation in many different trials. Mediterranean diet is the best eating program because it's anti-inflammatory. It does decrease inflammation and it does lower C-reactive protein. I love to use low-dose naltrexone for weight loss. It's compounded. I love LDN. Regular naltrexone we use at the usual dose for a drug overdose. In low doses, it is one of the best anti-inflammatories there is. So I use it for weight loss, autoimmune diseases, cancer, prevention of memory loss, treatment of memory loss, and so much more. I love low-dose naltrexone. Now, of course, if a patient is on a narcotic, or if they have nephritis, if they end up having major problems with their liver, then low-dose naltrexone is not for them. And do review the side effects and possible side effects before prescribing. One of the side effects of LDN is a decrease in appetite. So not only does it decrease the inflammatory process, it improves insulin sensitivity, increases growth hormone, decreases appetite, sugar cravings, and inflammation. So here's your mechanism of action of LDN. Here's the most common way it's prescribed, particularly for weight loss. It is a ramped up dose. So I have it compounded as 1.5 milligram capsule. The patient takes one capsule an hour before bedtime the first week. The second week, they take 2 capsules. So that's 3 milligrams. The third week, they take 3 capsules or 4.5 milligrams. And then I write another compounded prescription for a total of 4.5 milligrams as a single capsule. Potential side effects, insomnia is the most common. About 30% of people do get insomnia the first night, but then after that, it's only 1%. Patients can get vivid dreams, fatigue, loss of appetite, nausea, hair thinning, mood swings, and mild disorientation, although that's rarely seen. 4.5 milligrams is not for everybody. So if you see those side effects, then just cut down the dose. I have some patients that can only tolerate 1 milligram, some people 2 or 3 milligrams. There's your potential long-term side effects. Good sleep hygiene. In order for the patient to be really healthy, they have to sleep well. Chronic insomnia can cause an increase in insulin levels. Insulin goes up, the patient gains weight and doesn't lose it. 6.5 to 8 hours a night is the perfect sleeping pattern. Insomnia increases cortisol levels as well. Then the patient has a hard time losing weight again if they stayed stressed. This study showed that insufficient sleep reduced dietary restraint and led to weight gain in women. This review from 2009 summarizes the laboratory and epidemiological evidence that suggests how sleep loss, either behavioral or disease-related, and poor quality of sleep promotes the development of obesity and diabetes mellitus. This article from 2015 supported the contributions that sleep disorder plays in the development of obesity and all these other diseases as well. Fiber. Fiber makes the patient full, feel fat. Soluble fiber helps lower cholesterol, helps lower blood sugar, so it is great for weight loss. The same thing with water. You want that patient's skin to look great. They have to have enough water. They don't have congestive heart failure, renal disease, or some reason they need a restriction of fluids. Everybody else needs at least 1/2 their body weight in ounces every day. Water helps to detoxify. It does make the patient feel full as well. Yeast infections. The patient may have a hard time staying away from sugary foods. They tend to end up with yeast overgrowth and leaky gut. These are causes of yeast overgrowth. Even oral contraceptives can cause yeast overgrowth. It's not just a sugary diet, although that's certainly the number one reason. Decrease or eliminate milk is very helpful for these patients. Mold and yeast containing food should be avoided. So cheeses, dried fruits, peanuts, and alcoholic beverages. These foods as well tend to promote yeast growth. So dietary changes will help with yeast, support the liver. The patient may get yeast die-off, so they may get a headache, muscle aches and pains as you're treating their yeast. Some patients will need an antifungal medication, such as diflucan or nystatin. Many patients do very well with nutritional therapies as well. Herbal therapy should not be used during pregnancy. Garlic is great antibiotic, literally, for the gut. It's also wonderful to decrease inflammation, and it gets rid of fungi. Berberine is also fabulous, whether it's golden seal, Oregon grapefruit, golden thread, all of these others as well, red clover, artemisia, citrus seed extract, and essential oils, oregano, thyme, peppermint, rosemary. It can cause heartburn if enteric coated is not used, but they do help with yeast overgrowth. Tea tree oil, propolis, Ayurvedic medications can be beneficial as well. Artificial sweeteners are honestly not for anyone. Aspartame is 200 times sweeter than sugar, and studies have shown that aspartame use is associated with weight gain. Sucralose is 600 times sweeter than sugar. It's twice as sweet as saccharin and 3 times as sweet as aspartame. Artificial sweeteners can alter the microbiome, can cause metabolic changes. So studies found saccharin, sucralose, aspartame to lab animals and to humans. They show a change in the microbiome. So artificial sweeteners are not the way to go. A more natural sweetener like stevia would be a better choice. Food addictions. There is science, literally science and controlled trials behind these foods. Chocolate, cheese, sugar, and wheat, they really are addicting. Chocolate has opioid effects. It's rich in phenylalanine, which is an amphetamine-like chemical. The brain cells contain a chemical called anandamide, which is related to THC. Chemicals in chocolate delay the breakdown of anandamide, so the wonderful pleasant effect feels longer. Cheeses and dairy products have similar effects as well. Sugar is the most addicting substance there is. They actually did a clinical trial with little laboratory animals. They put out 2 bowls. The bowl to the right was cocaine. The bowl to the left, that bowl contained sugar. Almost 100% of those little laboratory animals ran to the sugar, not the cocaine. Sugar has an appetite driving effect as well. Serotonin levels decrease with dieting. So carbohydrate-rich foods boost serotonin production, but it has to be the right kind of carbs. A great way to help people lose weight is to get them off of gluten. When gluten's metabolized, it's broken down into compounds that have a very mild opioid effect, so it is addicting. The study, beneficial effects of gluten-free diet and reducing adiposity, inflammation, and insulin resistance. And then are there nutrients that can help? Yes. Carnitine can actually help burn fat, but again, get a TMAO level first. These are causes of carnitine deficiency. Sometimes it's medications. Every medicine that you or I prescribed causes between 2 and 10 nutritional depletions. So sometimes the etiology of these deficiencies, including carnitine, are related to medicines that we give. It does take 3,000 to 4,000 milligrams of carnitine to burn fat. There are some medications that can interfere with carnitine. Valproic acid can lower levels of carnitine, for example. Some nutrients help carnitine work more effectively in the body. Those are listed here. High fructose corn syrup. High fructose corn syrup is 50% fructose and 50% glucose. It contains up to 80% fructose and 20% glucose. Both sucrose and high fructose corn syrup contain 4 calories per gram. High fructose corn syrup increases triglyceride synthesis and fat storage by the liver. Wow, look at these stats. Between 1970 and 1990, the consumption of high fructose corn syrup increased by more than 1,000%. High fructose corn syrup is 40% of the caloric sweetener added to foods and beverages. Humans have consumed less than 15 grams of fructose a day from fruits and vegetables. Now, of course, so much more. An increase in consumption of high fructose corn syrup may be a causative factor in these studies of metabolic syndrome. It can contribute to obesity and insulin resistance. More studies showing the same thing. In this study, they discovered the use of high fructose corn syrup increased by 2,100% in that same time frame. The rate of diabetes went up astronomically. Another study showed the same thing. Patients started gaining weight. Yet another trial, men eating a diet of moderate amounts of fructose produced adverse changes in glucose metabolization in normal subjects and also in men who already had high insulin levels. High fructose corn syrup in large quantities elevates triglycerides and increases the risk of heart disease. Same thing in this trial and this trial as well. HDL actually goes down. Lipoproteins are then deposited in the vessel walls. Too much high fructose corn syrup contributes to high blood pressure. It contributes to gout. In this study, the use of high fructose corn syrup in beverages was associated with high uric acid levels. A Harvard study, quote, fructose-induced hyperuricemia might have a causal role in metabolic syndrome, hypertension, and other chronic disease. I think you're getting the hint here, right? High fructose corn syrup, not really very desirous. Contributes to an increase in non-alcoholic fatty liver disease, of which we're all seeing a lot more now. And the same thing with kidney stone formation. The consumption of large amounts of high fructose corn syrup actually causes glycation. The study showed the rate of protein cross-linking or glycation 10 times higher when the use of high fructose corn syrup. Over a long time, it is associated with adverse effects on aging. So the patient, if they want to lose weight and keep it off, it's many things. It's not just one thing. There are some new areas of research. We do know that weight loss and gallstone formation can be associated together. Nutrients that aid in promoting liver health are important, lipoic acid and milk thistle. The patient has a 20-pound or more weight loss, then the dose of their medication may need to be changed. So do not forget that. A lot of people will then come to a plateau stage. They lose 20 pounds and they kind of get stuck for a while. Encourage that patient. They will continue on to have more weight loss. Also, if the patient loses 20 pounds or more and they're on natural hormones, their hormone dose may need to be changed as well. So more research now being done on grenulin and PYY. Grenulin's an amino acid polypeptide. PYY is a 36 amino acid peptide that's synthesized and released from the distal gut in response to nutrient ingestion. Obese subjects have lower basal fasting PYPP levels. So the mystery to weight loss actually is no mystery at all. It's not simple, it's not easy, it's multifactorial. The trouble in today's world is everybody wants a quick fix. Oh, doc, can I do one of those detox programs and just lose 10 pounds? There is no one program that works for everybody. It only takes eating an extra 100 calories a day to gain 5 pounds a year. Successful weight loss requires that the patient have optimal hormonal and nutritional balance. Their body must be able to detoxify. They must have fiber. They must drink enough water, deal with their allergies, deal with their infections like yeast, inflammation, and absolutely, above all else, patients must have a healthy gut in order to lose weight and keep it off. Thank you very much.
Wasn't that great? Dr. Smith always has the best presentations. I love listening to her talk. We hope that you learned something new today and are excited about the information that was shared by Dr. Smith. We designed the Innovation Institute to provide you with the tools and education that you need to help grow your practice and increase your knowledge base. My name is Tara Thompson, and I'm a pharmacist here at Innovation Compounding. It is our goal to help you prescribe with confidence by going beyond traditional pharmaceuticals to create custom care plans that suit each patient's needs and provide them with a better quality of life. If you have any questions or clarifications about the presentation or the therapies mentioned for treatment, please let us know. Thank you for listening today, and be well.